that we'll be starting our talks with Dr. Sally and Dr. Sharon. Okay. We'll be starting our program with Dr. Sharon Dagger, and then in the middle of the program, we'll be doing our weekly rounds on our patients. So whenever they're ready, we're going to move on to that, and then get back to our program after that. So I'd like to present the first talk. Dr. Sharon Dagger, RT Yearly Education and Evaluation Protocol.
Good morning. Back again. We're going to do a little talk on education today. We are pretty instrumental in CF, in our institution, in all kinds of education with our patients. There we go. Okay. All right. In our institution, the respiratory therapists care for the CF patients, often from diagnosis, which is often in early childhood, through adult life. So we get to interact with our patients on multiple levels and multiple stages. We get to build lots of quality relationships with our patients, which makes it easier to do education. Efforts at education can lead to better lung health and quality of life, so it's a pretty important focus for us. So our approach to education is that every interaction with the patient and family is an opportunity to provide educational support. So from the minute you're hi, how are you feeling today? What can we learn about our patient? We are the first people that often see the patients at a clinic visit. They're coming to get their spirometries done before they see the rest of the care team. And so that's where we start with education right away. Did you take your treatments this morning? What have you done? What's your normal therapy routine? Then we get a first PFT, we get our first spirometry result. Are they coughing? What are we talking about after that? Do we need to practice huff coughing? So the whole time that we're with the patient is an opportunity to educate. And then on top of that, we do schedule yearly compliance education visits so that we can review a whole multitude of their therapies and equipment and all that stuff, which I'll get to a little bit later in the talk. So just going back to that, so in clinic, like I said, we start right away. Did you do your therapies today? What's your usual routine? Often, if their numbers are down, as we talked about at other talks, we have a protocol. So if their spirometry, if their FEV1 numbers are down 10% from their best in the last year, we're automatically giving them a bronchodilator. So it's an opportunity for us to review their technique with them, make sure right then and there how they're doing it, what they're doing. Now, they're also getting that spacer from us, so we know they're getting a new device. And then if we need to practice huff cough, if they're having a hard time, they can't seem to mobilize after a couple of attempts, then we'll have them do some huff coughing while they're right there with us doing their spirometry. Sometimes this is where we get a sputum sample. Spirometries are great. That forced effort's a great way to help them produce that for the clinic. And then we schedule our yearly evaluations with our patients. So our goals for doing that are multitudes. We discuss why therapies are important. We review techniques. We review their NBI with spacer technique. Most of our patients are on aerobicas or acapellas. We review that technique with the patients. We check their therapy vests. We want to make sure they're functioning properly, that their vests fit properly, it's inflating, and we're also checking on the device hours of use so we can kind of see how often, if there's very few hours of use from our last documentation, then we can kind of do the math and figure out, are you actually doing what you say you're doing? And then we review cleaning of equipment, which is super important in CF infection prevention. So we have a chance to have that discussion with the families. And we really stress that as they get older, of course, at the beginning, it's the parents, the caregivers that are answering the questions and are really getting the education. But as the children start to get older, we start to incorporate them more as the primary focus in our yearly education. Getting them to answer the questions, getting them to kind of be involved in their care and understand their care. So airway clearance techniques. This is where we start. We have a list of topics we go through when we're doing our education. Airway clearance is one of them. Can you explain to us why airway clearance is important in their minds? Most of them get it. It helps keep me healthier. My lungs are better when I do it. So even they understand the importance of it. We also want to check and make sure that parents in our institution, they're taught by PT early on some percussion and postural drainage. So we want to make sure even though they get a vest, they still have those techniques and are able to perform them in case their vest didn't work. They have to have another avenue to help do airway clearance. Can you have cough? Can you demonstrate proper technique? It's not one thing. They can say, oh yeah, I know how to do it. Well, show me. And then we review technique with them. And then does the patient, do they have an a cappella aerobica? If they brought it with them, can you demonstrate for us? How do you do this? And so that is really important to make sure that we're actually seeing them, not just that they're telling us to do something. Demonstrations are extremely important. Then we'll go through their vest. We have them bring all their equipment with them to their yearly evaluation. So that's a lot to ask the families to bring all that stuff. So we only do it once a year. And sometimes we ask, we can do it virtual care. So we can just see them in their home doing it. It can be the same effect. But when we review the vest, we're documenting all of this. And so we're documenting, what vest they have, what size they have, does it fit okay, the time for treatments that they're doing when they're healthy, just normal routine versus when they're sick. Is there a change? Have they modified that in any way? The number of treatments per day that they're doing. So generally, in normal health, they're doing 2 treatments a day, morning and night. Oftentimes we'll hear that when they're not well, that they increase their nebulized therapies or they increase their albuterol, then they're also increasing their vest. We check the frequency that it's set for. We check the pressure to make sure our inflation is good. We talk about adherence. So we keep that really simple. In the last 2 weeks, how many times have you missed doing your scheduled therapies? And that gives us a little bit of a snapshot as to what their normal routine is. I mean, some people are very diligent, other people that are really busy and have lots of outside activities after school, they may have missed a few. And so we try not to make them feel bad. We're just trying to get a feel for, how important this is to them and how they're fitting it into their daily life. And then we discuss some of our equipment has filters on it, so we want to ask the families if they're changing those at a routine basis. And then we also talk about proper cleaning techniques, which there are a few different: cold sterilization, boiling for the neb cups that are able to be boiled. And we review all that to make sure they're using the Foundation's recommended cleaning. Then we review their medications. We want to know that what order they're doing them in, so that they're doing them in the correct order. We also want to know if they know why they're doing them and what that medication does. Excuse me. At our institution, we're fortunate to have a pharmacist on our team. They also spend a lot of time with the patients, So this is just kind of a touch base for us, just so we know that, that we've had that conversation with them, but pharmacy really spends much more time with them in that education realm. And then we'll get them to demonstrate their proper technique with the spacer and a spacer mask if they're young, and so that we know that they're doing that properly. We talk about their equipment, so if they're on any nebulized therapies, then they have a compressor. We want to, make sure that it can handle high output, so we try to get them as close to a 50 psi compressor source as possible. We ask questions like, how long does it take for your treatments? Because we know if the compressor is functioning properly, then it shouldn't take longer than 15 minutes. Probably only takes about 10 minutes. So if they start to say for a normal 3 ml solution to be 20 minutes or more, we're starting to wonder if the compressor's wearing out. And then if it has a filter, have you changed it regularly? So we try to give them tips for a lot of these little things like the filter changes to, mark it on your calendar to coordinate with a clinic visit. That way it's kind of, hey, when I go for my second clinic visit of the year, I'm also going to change my filters. Just trying to keep it simple for them so that they don't have to track too many things. They have a lot that they monitor and navigate, so we just try to keep that simple for them. The foundation was very generous during the pandemic and supplied most of our patients that were over 6 and above with home devices, so we also incorporated that into our education. And so we asked them to bring that so they can demonstrate. It's a little bit different than how they do their spirometry in clinic, because it's a portable device versus being on the mouthpiece and breathing through a different system. We honored also during that time, we're using different reference sets. And so we hadn't switched to GLI in our hospital-based systems yet, but that's what the home spirometer was. So values were a little different for our patients, which they're very attuned to their numbers, right? Because they know if the numbers are a certain way, they'll probably have the potential they could get admitted or not. So they're very in tune with what their numbers are. And so we took a lot of time explaining the difference between the measured FEV1, the percent predicted, and the actual value, because the actual value won't change, but the percent predicted might with a different reference set. So we took a lot of time explaining that to our patients. We will also ask them to upload those images into the electronic medical record through their portals so that could be tracked so the physicians could see it. And then we talked about cleaning, which was a little bit different with that handheld device than with our others, because there really wasn't a good way to clean some of that, really just their mouthpiece. And so we spent time with that. And then we talked about the overall infection prevention and proper cleaning techniques for some of their devices, like their nebulizers. Are you cleaning them regularly? So yes, it's recommended they get cleaned after every use and then sterilized daily. That's a heavy burden for a lot of families. So, if they're honest, they'll say, well, we change them, we rinse them out, and we sterilize them every other day. At least we know they're doing something, that they know what they should be doing, and they have the correct information. If we're fortunate that our patients have the powdery nabs, they can be boiled, which takes a burden off of cleaning for that. That makes it easy. We want to make sure that they're rinsing with sterile water if they need to do a final rinse and not tap water. So we get them to tell us, what do you do at home? Some of the little ones use baby bottle sterilizers for their equipment. And so it just gives us a chance to have that conversation with the families and make sure that we're also sharing any current updates that the foundation has recommended for infection prevention. So in summary, so we talk about a lot. One of those sessions can be anywhere from 30 minutes to 45 minutes long. It depends on if there's questions. It just depends on how the conversations are going. And so basically, in summary of our education, repetition is the key to successful learning. So we schedule these sessions every year, or we try to. Can't always get them to come, but we would like to have this session with our patients once a year, every year up to the age of 10. And then after that, up from 10 to like 16, every other year. Because by then they probably figured out what they need to do, and it's really just a touch base. And then after the age of 16 until they transition to adult, kind of an as needed or recommended from the provider. And that's how we approach our scheduling of these. As a child gets older, they should be the primary ones communicating during the assessment. I will right away turn to the 10-year-old, and I'll just kind of put my hand up to mom, who's ready to answer, because she knows it all. I'm like, no, I want to hear from so-and-so, and then get them to get comfortable talking about their health, talking about what they do, because when they can tell you what it is, then you know they understand it. So that's a real important part of it, because at some point in time, they're going to be responsible for it on their own. So they need to, the earlier they start with that, the more comfortable they get being able to be their own advocate. We share knowledge that's learned. Anything we hear during our assessment, we share forward to the care team. Sometimes we're seeing that doing these assessments after they've already seen the care team in clinic. It's just the way we can schedule it, sometimes before, but we always circle back and then share. Is there something that the doctor needs to know? Like, this is what actually came out at the treatment. And it's the same as if when we're doing spirometry, sometimes we hear something from the patient and we share that forward to the care team immediately. Should be aware. They say they really haven't been doing their stuff and their numbers show it, and so things like that. And then we always try to reinforce good behavior. If they're making the effort, if they're doing what they're supposed to do, we want to give that positive feedback. We realize that it's a huge burden on these families to just do regular CF care. They spend hours a day just to stay healthy, so we want to encourage that's worthwhile. That's what we do. Any questions? Okay.
So can you go over the cleaning that we tell the families to do?
Yeah.
You know, that's a month.
Yeah.
Water or whatever.
Yeah, so there's cold sterilization methods. So you can do, most people use isopropyl alcohol as a 5-minute soak in isopropyl alcohol, and then rinse with sterile water for their cold stuff. So their aerobica, the things that can come apart, they could do it with their nap cups too, and anything that you can't, that's heat sensitive, you wouldn't put in a high temperature, you can cold sterilize. An important thing there is to rinse with sterile water. So we just tell the families they need to boil water for 5 minutes and store that in a jug for about 24 hours. You know, if it's cool, maybe 48. We don't want that water to start to grow anything, so we don't make a big jug of it. Do a little bit at a time. And then we do that. They can also use hydrogen peroxide 3%. It's a lot harder to come in, and that has to soak longer, so that's not a great option, but it is an option for them to get a bowl of hydrogen peroxide and soak them in. Again, sterile water rinse at the end. If anything can be boiled or put in the dishwasher. Dishwashers can be used, but you have to know they're getting to 160 degrees for that duration of time. So it's kind of, we don't know. I mean, the manufacturer may say it gets there, but we don't really know how that's functioning. Those are the big ones. So the Pari cups, they can be boiled for 5 minutes, and then they don't need a sterile water rinse because you just boiled them. So then everything needs to be dried completely
air dried, and then stored in a lint-free container. You don't want anything stored damp, you don't want it to grow mold or anything like that. So that's really that. And then we just ask people to, make sure they're wiping off their equipment, wiping off their vest, wiping off their compressors, just to keep lint and dust and most of these things, sit on a table, some may even sit on the floor in a room, just to keep, those devices in trained air. So we want to make sure that we aren't, keeping them working properly. So just keep them wiped off and clean.
I have a question,
Okay.
Sharon. First of all, thank you for this interesting talk. And we have a lot of patients who buy the nebulizers, and they would have the attachment, the hose with the cup and the mask and everything. And after a while, or maybe they will have several children to use it, they will get a generic one, which is sold in the normal pharmacy or store. My question is, sometimes the generic ones are not really working so good with the nebulizers that, like the first piece that was originally in the box. So my question is, are all of these hose and cup thingies compatible with any compressor device? Or is there something to look for when you're buying, I don't know, maybe?
I would think the hoses are standard size, just like our aerosol tubing's a standard bore size. I would think that, just like oxygen tubing, any kind of tubing that fits on that adapter should work. There's no connection to the patient, there's no worry of infection prevention in that. So, it doesn't mean that over time that if you're taking that on and off, you're not, loosening it, it's not making a good enough connection, but you should still, it should work. That should work. I would think the more concern is the type of nebulizer cups they're getting that may not nebulize to the particle size. So maybe that's more of an issue than the tubing.
So you mean the small cup where they put the
Right.
solution and the medicine in, that's not compatible with all pressure nebulizers?
No, it is, but what I'm saying is some of those, the particle size they generate when they're nebulizing may not be the same for all of them. It's probably a general range, and so if they say they're not working as well, it could be the cup, not the tubing.
Thank you. And is there like a recommendation for how long is the tubing attached to the nebulizer supposed to be changed? So
No, I think we just have to look at it and make sure that it actually is staying on, it's not popping off, that it actually makes a good connection. There's no recommendation out there as that it needs to be changed with any frequency, unlike the cups. If you're using a reusable cup, then that you're changing those every 6 months, because that's what the studies show, that they will hold that particle size for, like a Pari cup is good for 6 months reused. Your disposable cups should only be used for 2 weeks, and then replaced.
Okay, so I'm not so sure our patients will change those disposable things for 2 weeks.
Yeah, again, that's how.
Keep them until they're not working.
Yeah, so I would say if they're not working, then they probably need to change their cup. And it's not the tubing.
Okay, and another question concerning the spacer device,
Yes.
the air chamber. So we have a lot of generic air chambers, and my question is, would they be as functional as the brand ones? And if the patient loses the valve thing,
Yeah, so
can they still continue to use it, or should they just replace it?
well, the valve serves the important purpose of one-way flow. So without the valve, then, are you potentially, it's not staying contained in there. So that would be my concern about the valve not being there, because then you can blow into it. Then you have to worry about infection inside the chamber. Whereas right now, you really just need to clean the mouthpiece, because if you have that one-way valve, nothing is going in. It's, you know, it's coming through from your medication to the patient. There should be nothing that comes back towards the patient, but if you don't have that valve, then you're at risk for stuff being in there and contamination. But I would think that they should be fine. That's really there just to kind of hold in suspension for a short period of time to allow them to take that nice deep breath. It's very hard to coordinate the puff and so it really, it's designed to make that a much easier process to ensure you get the dose of medication that you should get.
Thank you. Any other questions?
And any generic imaging is fine.
Yeah.
As long as they're valved.
Yeah, that's what I think is about.
Yeah.
But not, everything means any commercial one.
Yeah.
Doesn't
Not
matter.
to worry about like the staffing and all. Okay, thank you Sharon so much. It was very interesting. And again, Dean and Dr.